You're not waiting for something bad to happen. You're catching things early to prevent something bad from happening. We want to keep the sleeping dragon asleep.
Hi, I'm Dr. Phil Goche, a transplant nephrologist and Senior Medical Director at Natera. Today, I'll be talking with Dr. Rodolfo Batarse, a transplant nephrologist and President of Desert Kidney Care. Dr. Batarse will discuss the importance of proactive, vigilant maintenance with Prospera for transplant recipients. He will describe a case in which Prospera allowed him to make a diagnosis of antibody-mediated rejection despite a negative biopsy. And finally, we'll learn why a kidney transplant and a Ferrari have more in common than you might think. Enjoy. How are you today?
Doing very well. About yourself?
I'm doing great. Thanks so much for being here. So I would like to start by asking you to describe your current practice.
So, I am a transplant trained nephrologist, and I work now in the community out in Rancho Mirage, California, serving all aspects of general and transplant kidney care.
Great. And how long have you been using Prospera?
Prospera since it came out a number of years ago.
So you were one of the originals, huh?
When you read something, you say, I think we're onto something here. Then I jumped on the boat quickly.
Great. So it was the early detection that first piqued your interest.
Yes, indeed. Early detection before the creatinine would see a change. And of course, time is kidney. The earlier we can see changes, the earlier we can act, we can avoid a major immunologic catastrophe.
I see. And what has been your experience with Prospera since you've been using it?
Really, it's actually not only worked quite well, but it's easily accessible. So the one thing for me is not only does it work correctly for the patient, immunologically, and for me as a physician to help me guide therapy and to maintain and have a vigilant and proactive type of a program for the patient, but something that's available to them. So in both aspects, it has actually worked quite well. So I've been able to prescribe it. Fortunately, without much fanfare, patients take it because it's a blood test for them.
Right.
It's no different than getting blood for any other physician or any other lab test. And the results come back in a timely fashion. Fortunately, should there be an abnormal or an alarming result, I am alerted of it, as is my medical assistant in my office, so we can act on it quickly. And the patients get a call, and then, of course, we review it during our transplant meetings.
Well, that's great. So it's easy to get for your patients, even
Yes.
the ones that live far away?
Yes, working in Rancho Mirage, working in the Coachella Valley in California, we cover a vast geography. Low desert, high desert, mountains. I mean, some of my patients drive 2 hours to see me in the office. And the fact that there is availability of in-home support, meaning that the test can be drawn at home, is a godsend to many of these folks. Not only because of the remote nature of where they live, but someone may not have the availability or accessibility to go to a lab quickly, close by. They might be not have transportation available to them all the time.
Right.
So it really makes that aspect of the care, A, convenient for them, which is key, and B, to me as their physician overlooking their care, it brings a lot of comfort in the knowledge that I know that the test will be drawn. And if it isn't for some reason, I'm notified, and then we can work out the details.
Right, and I understand we can get the other labs as well at the same time as the Prospera.
Which is fantastic. So of course, the patients love it, right?
Yeah. Okay, and I understand you have a regular protocol for the use of Prospera. Could you please describe that and which patient types you use it in?
That's a great question. The protocol is really all about vigilance and about being proactive. I mean, we're not waiting for the car to break down.
Right.
Why do you change the oil at 5,000 miles? Why do we rotate the tires? They're black, they're round, and they move. It's maintenance. You're not waiting for something bad to happen. You're catching things early to prevent something bad from happening. And in transplantation, which is key, of course, as a transplant nephrologist, this is what we do for a living, but other nephrologists or perhaps other specialties may not remember that the immune system has memory.
Yep.
We want to keep the sleeping dragon asleep. If it wakes up and notices, that's where you have chronic rejection, of course, antibody-mediated rejection. So we want to keep this, the immune system suppressed. And part of that is constant vigilance, constant adherence to the regimen, and of course, fine-tuning of that.
Right.
With that, proactive vigilance and maintenance with Prospera is a key part of that. With my patients, since I see most of them about every 3 months or so, then Prospera is ordered every 3 months. It is part of their routine transplant labs. Now you could say, well, aren't some patients perhaps higher immunologic risk, perhaps higher logistic logistic,
Logistical risk. Or
risk, exactly.
resource challenge.
Exactly. And the answer is, of course, it depends where they live and what they have available to them. But in my view, the care shouldn't change. You just fine-tune it and personalize it. So because of my geographic location, I treat all my patients as high-risk patients because they will fall into one of these categories. Of course, if they already had a rejection, if they were highly immunized before the transplant, if they already had positive DSAs from the transplant center, if they've had multiple infections, if they've been in and out of hospitals, if they've had a blood transfusion, all these things, of course, raise their risk and, of course, are taken into consideration. But to me, to keep it as simplest as possible, to get the protocol to work correctly, and to get everybody on board, my office, the patients, their family, and everybody involved, you do it this way, and I think you start finding trends, and we follow trends, and then we notice changes in trends very quickly.
Oh, that's interesting. So can you talk a little bit more about how you use the trends in both donor fraction and donor quantity rather than just the absolute value?
So what we do is, when you look and you start following the Prospera levels, and when you start looking at the fractions, you'll initially, when I started using Prospera, I would try to establish a baseline for a patient.
Okay.
What was their baseline? 0.1, 0.2, 0.4, 0.5, 0.8, whatever it may be. Admittedly, in the beginning, or since the beginning, there's been a lot more research done since then. But in the beginning, once I established a baseline, let's say, just for sake of example, 0.5 to 0.6%, then if it started to creep up, 0.8, 0.9, hey, it's still below 1, which means it's still low risk, at least in general population. For this patient, however, it has doubled. So at least it piques my interest. It went from 0.4 to 0.8, 0.4 to 0.9. I say, hey, something's happening here. Let me look at their Prograf levels. Let me look at the cyclo levels. Let me look at their immunosuppressive levels and see, have they been subtherapeutic at any one time? Have they had a recent infection? Did they have BK viremia? Did they have CNV? Did something else happen? Let me delve in a little bit deeper and see, do I need to increase the immunosuppression? Do I need to modify it in one way? Again, it just raises a flag, and instead of having them come back in 3 months, I may say come back in 6 weeks. Why, doc? Because I like you. Just stop on by, we'll keep you running well, okay?
Okay.
So that kind of thing, right? And we establish, maybe the next time it's slower, maybe the next time it's higher, and it's time to really act right away. But you catch it early. You catch it before there's a major problem.
Right.
That's the idea.
And certainly that's how we use serum creatinine, right? I mean, sometimes a 1.5 is great and sometimes it's terrible. It depends what it was before.
I agree with you wholeheartedly.
Yeah, okay.
So in the same way, of course.
Okay. So can you describe a case in which Prospera was particularly useful?
There was a patient recently, young guy, 47, straight shooter, as I like to say, shows up to the practice, knows his medications by heart, knows when to actually have the Prograf level drawn in the morning, knows about the empty stomach protocol, not eating before taking the Prograf. And I mean, the guy, he's a grade A student. I really like him. He's just a good guy medically. He has support from his family. And he's really just a pleasure to work with. We started getting Prospera from the get-go, as I mentioned, 2021. Boom. His levels were always a little bit higher than 1%. They hovered around 1. I said, well, maybe this is his baseline.
Okay.
Maybe this is his baseline. I don't know. We don't have anything else to go with. And again, his Prograf levels were always within target, and the lower side of target, but within target.
Okay.
I said, okay. Over time, however, it would bounce up and down. And then we would have starting the absolute, copies per cc's, which were always on the higher side, never eclipsed, into the abnormal or the alarming level. And then in a routine visit, I noticed that his Prospera jumped from just over 1% to over 4%.
Whoa, that's high.
Yeah, we're not talking, you squint.
That's not subtle.
Yeah, you're not going 72 in a 70 mile per hour zone. I mean, this is boom.
Guilty.
Slap in the face, right? So I said right away, this is a routine one, okay, coming into the office. I brought him in right away. I said, look, we got to get this tested. I'm working. I'm glad you're working. And you're working because you have your health. And you're working and you have your health because your kidney works. So let's work on you getting that test today. Okay, doc, let's do it. We got him that test, and of course it came back, and it came back almost as high.
Wow. In
the 3% range, okay? And I said, okay, this is legitimate. This is real. This is what we're going to do. Okay, he's back in the office. I said, come on back. Now, I've seen this guy for eight years plus.
Wow.
So just the fact that I brought him back a couple of times in the week, I said, sir, listen, if I'm getting nervous, you should be nervous too. This should be alarming. How often do I bring you back this much? I said, we need to give you the Solumedrol, steroids and the like. We set everything up, high dose steroids by pill afterwards. He said, okay, doc, I'll get it done. And we need a kidney biopsy. My MA really is very thorough, knows how to get it through the hospital. We had the biopsy scheduled within 48 hours, and that was the plan. So that's
the plan.
The plan.
Uh-oh, I can see where this is going.
Yeah, it's the plan because he canceled it. I called him the next day, and I said, hey, sir, how did the biopsy go? I canceled it. What are you talking about? Yeah, it clashed with my work. I'm like, look, man, I want to break it down for you. How often have I called you at home following up on a procedure or a lab test? This should be a little flag that goes up and says, hey, something's happening that Dr. Batarse is calling me so much, okay?
Yep.
So I said, look, we're going to reschedule it. I don't care what happens. Please cancel. I'll write whatever note you want for whatever you're doing. You got to get this done. Time is not on your side. We were able to have the kidney biopsy done. He did get the immunosuppression, the steroids and the like. And then we had the result. I called my colleagues at the transplant center close by, which is where the patient had his transplant about 8 years prior. Called them and said, look, this and this is happening. Prospera is high. Got the biopsy. It shows this. Early antibody-mediated rejection. He's already had the Solumedrol for 3 days. This is high-dose prednisone. Tell me what you want me to do. Because this here we're working together. Of course, everybody has slightly different styles.
Right.
Was able to get IVIG and able to continue the steroids. Prospera plummeted. For the first time since it was checked, the Prospera plummeted to less than 1%, down to the 0.3 range.
Wow,
so that brought to me two things. One is this whole time that his Prospera was always a little bit higher, in the 1% range, that there was some immunologic phenomena happening. That there was some low-level damage happening. Of course, I didn't know that at the time. No one knew. I mean, the data came after. In retrospect, now we know, and of course with the data that's come up since. So that's the first thing. So it would be exceedingly rare to have an abnormal Prospera value and say that's a false positive.
I see.
Look, nothing is absolute in medicine or in life, but it would be exceedingly rare. Recheck it again just like it did. That's number one. And number two, with proper immunologic therapies, it plummeted. Which means that the Prospera noted A, the damage, and noted B, the improvement after the proper immunotherapies were delivered. So to me, that was fantastic. I mean, it was beautiful watching this happen. In the following weeks, the Prospera started to creep up again. Over one again, because I checked them more often, of course. And I called them up. I'm like, sir, listen, you know that I think you're a straight shooter. Are you taking your medicines like you're supposed to? Just be honest with me. I need to know. Are you missing any? No, doc, no, doc. Well, eventually, look, I miss one a week, maybe 2 a week. Look, just tell me. And maybe it was 1 or 2 a week. And I still think that's pretty darn good for all these folks taking 1 million pills.
Yeah.
But these are obviously very specific, unique pills that are time sensitive, time dependent, and of course your body and your life and your health depend on it. So that's why I'm so vigilant about it. He understood, of course. And I said, look, I'm going to call the folks back in your transplant center, called them, arranged for IVIG again, infusions once again, plummeted down to the 0.4 range where he has been since. So, I call it a flesh wound, and boy, what a
scratch.
Yeah, exactly. What a save.
Yeah.
And I keep looking at him because he's exceedingly fortunate to have his first transplant. I've told him he's exceedingly fortunate to keep it as good as it is. Because he keeps asking me, why did you get so nervous?
Yep.
Or why did you get so excited? Because from his point of view, I was getting excited. I'm like, sir, I might look excited because I know I need to do things right away to save the health of your allograft. Saving the health of your allograft keeps you from dialysis. That's all I'm thinking about. It's your overall health and, of course, the health of the allograft. And this is why I did this, and this is the outcome.
Wow.
I think he understood, but perhaps not to the depth, of course, that I was going through in my mind. But, I said, beautiful. Creatinine didn't really budge, still at his baseline.
So creatinine was normal the whole time?
Yeah, stable. His baseline creatinine, 0.9 and 1.1, just hovers there. No overt proteinuria, no overt hematuria, no hypertension, nothing. To him, why am I going through all this? Why is Batarse getting so excited about all this stuff?
Yeah, it's a powerful story. I mean, the next thing you know, he would have been in full-blown rejection.
100%.
Yeah.
If we didn't have that, I would have acted and continued to keep the Progaf level where it was. I'd tell him, hey, have a great day. See you back in 3 months. And in 3 months, either A, I would have seen him with full-blown rejection, with kidney, allograft failure and about to start dialysis, or in the meantime, perhaps seeing him at the hospital with uremic symptoms.
Wow.
And by that time, horses out of the barn.
Yeah,
And
for
then
sure.
we would have been up, really, really had a tough job ahead of us to reverse all the immunologic damage.
Yeah. So can you talk a little bit more about potentially using Prospera to manage immune suppression?
So the big thing, of course, now as I gain more experience and I'm familiar with the test, even as patients, say, who are first transplant recipients, okay, they're their first allograft from a living donor, low PRAs, low immunologic risk beforehand, young donor, we can consider them a lower immunologic risk. A lot of centers may use a steroid-free or a rapid steroid taper type protocol.
Right.
All right. Which in my mind, great. If they qualify and the patient is that type, both immunologically and also because of their commitment and adherence to the plan, beautiful. Let's get that done. But again, it's something that's even used with more vigilance and with more attention and perhaps even more frequently, just to make sure that there's no changes in the immunology.
Right.
Because you can catch things early, again, before you have a major immunologic catastrophe. Or when immunotherapies are changed.
I see.
Let's say I'm going to go from a Prograf or cyclo-based regimen to a Rapamune, as an example. Or let's say I'm going to go from cyclosporin to belatacept. And these changes, where you're changing the pillar of immunosuppression in these patients, even more to my favor, that you want to make sure that there's no immunologic mishaps, and you can follow the Prospera and make sure it stays low. Because if it starts to get abnormal, do we need another bridge? Do we need to do something else? Did the patient not take it? Obviously, all these questions run through my mind, and bring the patient in and let's talk.
Yeah, that makes perfect sense. So let's segue a bit, and I'd like to ask you, how is Prospera particularly useful in a community nephrology practice versus a transplant center?
The transplant centers, we're really fortunate because we have a lot available to us very quickly. And it's things that truly we take for granted unless we step outside of that center. We have labs devoted to transplant, meaning our patients can cut through the line and go straight to the front so they get a true trough.
Yeah.
We have labs, machines that run all the levels right away. Blood is drawn before 8 a.m. The result comes at 1 p.m. or after 1 p.m. We know we're going to get it the same day. We have all the immunologics available to us at a moment's notice. We have a transplant pharmacist, and all these things, a transplant floor, transplant trained nurses. The whole team is there and devoted specifically for the health of the patient with a solid organ transplant.
Right.
That's a luxury. In the community, we don't have that.
I see.
Now, mind you, we're not meant to. We're not transplant centers. But we also have to understand what we have and what we don't have and how we navigate this. So in the community, if we draw a Prograf, cyclosporin, Rapamune trough, and it takes 5 days to come back, you see the difference just in timing.
Right.
Okay? And the difference in when you can act. Or if rejection is diagnosed or suspected, how quickly can you get something more than high-dose steroids for the patient? Well, we don't have it available. It's just not available. It's not meant to be available. It's meant only at a transplant center, so we have to refer them quickly, and they have to go, and how do we get all these logistics passed? And within that realm, too, it's what I like to call the Fiat versus the Ferrari. Two, little red Italian cars, but you might drive them separately, or you might maintain them separately, right?
Yep, for sure.
All right, so one deserves, in my mind, a slightly more specialized, mechanic or technician, right?
Right.
Well, all my transplant patients are that Ferrari. So if they go to a community hospital and say they're a kidney transplant, they're doing great, someone sees their chem panel and says a creatinine of 0.9, they're not even going to ask, are you a transplant recipient?
Right.
That patient may forget to mention it.
Yeah, that's true.
And that's where sometimes the misfires happen, because no one appreciates that it's a Ferrari, that you're not supposed to give this medicine, that there are interactions and so forth, okay? So that being said, this is where, A, obviously it's education of the patient, B, it's education of the system and the labs and so forth. And this is where the Prospera in general can help me as the physician overseeing the immunosuppressive care, make sure that there haven't been these mishaps, that they haven't taken any medication that perhaps changed their immunosuppression, and then exposed them to immunologic risk. So it's something that really it gives me that peace of mind in the grand scheme, that the patient's taking the medicine correctly, that the correct labs are being done. Big picture, big picture. As far as if the Prospera is normal, let's say, but the patient presents with kidney injury, then I know I have to look for non-immunologic causes a bit more. Really, it goes back to the history. Of course, we take it for granted. That's what we do naturally in discussion, but we really have to concentrate on that. Many patients will forget to tell you they fell and hit their kidney. Or, or one forgot to tell me that they had a car accident. They were the passenger. Nothing crazy. I mean, it didn't total the car, no airbags. I mean, but the seat belt goes right over the allograft. So the nice boom said, sir, that's kind of a big deal. Yeah, I'm fine. But the kidney, man, the seat belt goes right over the allograft.
I didn't think about that, I guess.
So it can kind of just physically rattle it a bit, you know. And sure enough, let's follow, make sure that things are okay. So that again brings peace.
Yeah,
beautiful.
That's great. So it sounds like it's kind of a safety net as well as something that can help you with coordination of care.
100%, 100%. And again, I'm fortunate in that I have the transplant background. I know what to look for, of course, and to discussion in discussions with my colleagues and many of these guys and gals I know from before in my time at the university. But even if I did not have those connections, if I did not have that relationship with them, I would feel comfortable saying, hey, look, guys, this is not normal.
Right.
My understanding is that this needs this and this and this. What's your opinion?
Right.
And you let them tell you, of course, but at least it gives you that extra oomph to say, look, I need to speak to them today, not tomorrow.
Right.
Or we need to get this right now, not I'll wait for the call, in 24 hours,
Okay. So we talked about how the Prospera helped you identify a patient who may be getting into trouble. Do you think the opposite is true? Like when you see a patient who's consistently low, does that make you feel good and maybe you don't need to see that patient as often? Or
So that's a very good point. So let's say creatinine is stable. Maybe they've had the transfer for 10 years and it's 1.2, 1.4, 1.5. They've been rock steady with their immunosuppression, and the Prospera is always say 0.2, 0.3. While it gives me a lot of comfort in saying that the patient's adherent with the medicines, that immunologically everything's going as planned, I don't loosen the leash, for lack of a better word, because I do believe strongly that repetition is the branding iron of knowledge, and I do believe strongly that constant coming to my office and hearing, what I have to say, which is really the same message, and they bring all their medicines. They already know I'm going to ask them about blood pressure. They don't know about this. They can almost just tell me everything I want to know before me saying anything, because I ask them and they know the process that I go through, a very systematic approach. And obviously, in the meantime, we discuss other things, but they know. And A, it's keeping them honest. B, they appreciate coming in and knowing the fact that everything is okay.
They feel cared for. Yeah.
Exactly. And that everything's okay. I could tell a patient, let's not see you in 3 months. Let's see you in 6 months. They'll say why. I guarantee you they're going to say why.
Okay.
How come 6 months all of a sudden? I could say you're doing great. They're going to, but don't you want to keep an eye on me?
Yeah.
I mean, they would challenge. Obviously, they know my style by now, but the whole idea is that frequent maintenance, frequent monitoring with fine-tuning is much better than infrequent maintenance with a major service where you can have, again, catastrophic immunologic, problems. And not only for the current allograft, but obviously for future transplants should they need them. This is a long-term, big picture thing,
I don't know about you, but I know for me, it's good for my morale to see patients that are doing well in between the ones that aren't. So you're so right, because gosh, it feels so good. I often tell them, that they're the healthiest sick people I know. There you go. All right, so let's shift gears for a minute in our Ferrari and talk about the ProActive study. So I know you're familiar with the data from the first analysis of the ProActive registry, which has recently been accepted for publication in transplantation. So could you tell me what you think of those data, and were there any surprises there?
I would say that the biggest take-home message of the ProActive data is the fact that you can identify whether it be T-cell mediated or antibody mediated rejection earlier than you would with creatinine alone. Wow. That ties back really to the whole purpose of vigilance and proactive maintenance. If you can catch it early, you can act early. And if you can act early, you can prevent, again, damage to the kidney. If it's 4 months for antibody mediated rejection and you can identify T-cell mediated rejection 2 months earlier, that is fantastic.
Wow.
Because you can act earlier. You can do things earlier, make appropriate changes, and really avoid damage later on. Which of course was personified with the example I gave you earlier. It was caught early and we were able to adjust. That to me, it's key. Again, going back to acute kidney injury in general, even non-transplant, we're looking for markers for early detection.
Right.
Because we know the limitations that creatinine has inherently with that value. This is it. We finally found one. And we can use it, and it's available now. So within the transplant community and the kidney transplant community, to me, this is fantastic.
Great.
It's here. Let's get the show on the road.
Yeah, and it sounds like it kind of resonates with what you see clinically, because that's a pretty good description of the case that you had.
Yeah,
It went up
100%.
before the real full-blown rejection, so
100%.
that's really good. So what advice would you have for a community nephrologist who wanted to start using Prospera for surveillance?
You know, I would say as a community nephrologist, we are really not only the nephrologist, we're the transplant nephrologist, and we're really, in many times, almost a primary care to our transplant patients. They look to us for everything. Many times I have to say, you know, sir or ma'am, that's outside my realm or my umbrella of coverage, let's say, but I'll refer you to the right person. Or, you know, I trust this person, and yes, that medicine is correct, or that medicine doesn't interact with your program or your cycle. And it's great. I appreciate the confidence they have in my care, in my opinion. But as a community nephrologist, this is something that I can order. It's not difficult to order. It is not a transplant center only type of test. Donor-specific antibodies, great addition to the to the diagnostic and follow-up therapies that a transplant center can offer. We can't really do that in the community. That's not really available to us.
I see.
You know, and especially and if you have a community setting that's really physically far away from a transplant center.
Right.
That's not for us. Not because we can't order, of course, any physician can. It's just the logistics of the patient getting and interpreting and this and that. This is something that as a community nephrologist who takes care of transplant patients, we can order like any other lab test. The report comes in a very easy to read program and report, and it has two values that are key that you look, you interpret, and if you have questions, you have support of the staff.
Right.
That type of support to my practice and the type of support to the patient is invaluable.
Huh.
So now I have another test, I have another way that I can follow the patient and monitor, which is fantastic. Some colleagues may say, no, that's a transplant only thing. Well, it's for transplant patients, that I agree, but it's not only for transplant nephrologists or a transplant center. On the contrary, I would say that we all, if we take care of kidney transplant patients, that is something that should be part of our regular care.
What about cost?
You know, nothing is ever, if patients can't afford it, then it's not something obviously that can be given, that can be drawn, that can be prescribed. And that's a reality, of course, of the world. Fortunately, that hasn't been an issue.
Oh, good. Well, that was really great. Do you have any other comments to make before we wrap up?
I would say that we must remember our patients are exceedingly fortunate to have a kidney transplant.
Yep.
None of them chose to have kidney disease, and they chose dialysis even less. I always tell them dialysis chose you, not the other way around. And I know that not one of those patients, not one, wanted to be on dialysis.
Yeah.
To have that kidney, to be given life again, it's fantastic.
Yep.
So we are the caretakers of that allograft and of that life, that new life. I always see myself as a transplant nephrologist, really as the OB of nephrology. We're giving new life.
That's right.
You know, and it's fantastic. So you have to really respect it that way and say, we got to do everything we can for the patient.
Yeah. Well, thank you so much, Dr. Batarse. That was really interesting, and I really enjoyed our time together. Thank you.
My pleasure. Thanks for having me.
All right. Thank you so much for watching us today. Don't forget to subscribe so you'll receive early notification of our next exciting episode. And watch your inbox in your email for further content. Thank you.